So good afternoon, everyone. This was basically, I submitted it only because I wanted to discuss whatever cases we have seen, which we assume are related to COVID infection or COVID vaccine. Um, yes. Okay. So I have two papers. I'll present them one after the other. So one is the retinal sequelae of COVID-19 infection. These could be classified as infections secondary to immunosuppression that were caused by the COVID infection and its treatment, or as post-viral sequelae, or as treatment-related adverse effects from steroids and voriconazole and retinal vascular occlusions. So this was a 46-year-old male who called while he still had COVID infection with symptoms, and when he came to us, this was the picture. Vitreous was full, appeared to have fungal endophthalmitis, though micro was negative, resolved with treatment. Another was an aspergillus endophthalmitis with a cerebral lesion as well, and this was biopsy micro positive for aspergillus. Then we had a patient during COVID sent to us after he recovered with candidemia, and on routine screening, candida retinitis, which resolved with treatment. A lady who called when she had COVID, she was on steroids, which led to de novo diabetes. A common theme in the previous endogenous ENDOF also was steroid causing de novo diabetes. And COVID itself also causes immunosuppression, leading to these secondary infections. So she came to us when she recovered, and we treated her with anti-tubercular therapy, presumptively because all tests were negative. A young male whose AIDS was diagnosed during his COVID infection because of the additional immunosuppression, and a tuberculoma. Another elderly male with a choroidal abscess was referred because he was not responding to steroids, started during COVID infection, treated him with levofloxacin, and then also his toxo IgG was positive. So added Bactrim, he recovered his vision. Then we had a young man with triangular scotoma, and OCT showed corresponding area of RP disruption where there was a whitish lesion on the fundus, and superficial lesions suggestive of PAM, deeper lesion called AMN. This is a known post-viral phenomena. We had an elderly man with post-viral retinitis, responded only to steroids, and another younger male responded only to ranibizumab. The macular edema component responded only to anti-VEGF, not to steroids. We had patients with voriconazole who were on voriconazole, multiple non-specific symptoms, but evaluation including perimetry was completely normal. So finally we reached the diagnosis of exclusion, which was voriconazole related symptoms. Then this happened repeatedly in these patients because they do have fungal infections and are on systemic voriconazole for those. We had CRAO as part of mucormycosis, not otherwise. And again, most of these patients were de novo diabetics because of steroid during COVID. And then we had one patient with CRVO following a few weeks following his COVID infection. And again, he needed an anti-VEGF for resolution of edema. Steroids alone was not good enough, steroids and anticoagulants. Thank you.